And Jennifer, thank you for being with us today.
Thank you very much, Allie. It's nice to be here, and I appreciate anybody who's able to join to learn a little bit more about patient-centered medical home. Some objectives for today is to get just a very basic understanding of patient-centered medical home. We won't go into some of the real fine points in the scoring. It's a fascinating piece of PCMH, but this is more of just an overview and to be able to determine some easily obtainable factors, some best practices to achieve these factors, and then some strategies for your site. So what do you do now to get started? So probably the first thing when considering becoming a patient-centered medical home is to realize that there is going to be a change in the thought process and definition. So instead of it being a patient going to a physician who has ultimate authority, it is now transitioning more to you being a healthcare partner with a team led by the physician, helping in making shared decisions in your plan. It looks at more the whole person at all stages in the life, acute, chronic, preventive disease, end-of-life care, and very coordinated care is what PCMH is. So if you're ready to think and work as a team with the patient being part of your team, then PCMH, it might be the right time. This is I love this quote. This is from NCQA, the nothing about me without me. That kind of sums up the patient-centered medical home piece. Because it is truly care centered around your patient. PCMH eligibility, it is at the site level. So you may be familiar with meaningful use, which is at the provider level, the specific provider level. Patient-centered medical home is per site. So there's a recognition per site. And then at that site, you list the providers that practice there. So a provider can be at multiple PCMHs, again, because it is recognized at the site level. The structure of PCMH, this is an important piece to understand when diving into patient-centered medical home. Once you get the standard elements and factors down, then it's very easy to read and follow and to create a plan. So the structure of a PCMH, there are standards, elements, and factors. We're going to look at each one of them. The standards are the big umbrella. It's the overall concept. There are 6 standards in patient-centered medical home. They are listed here, patient-centered access. That is a big concept. Where do you start? Patient-centered access. Team-based care, again, that's a big chunk. So again, we're looking at the standard. Under each standard, there are several elements. So the elements, these help determine the points that you would achieve. And it provides more detail to the expectations under the standard. So looking at the standard 1, the patient-centered access, again, that's a huge piece. Element A, one of the elements under standard 1, is looking just at patient-centered appointment access. Well, that makes it a little bit more manageable. So we're looking in this section at just appointment access. And then factors, these are the actionable items that your office can do. You don't have to do every factor in the whole PCMH plan, but you would choose the factors that you want to do. So again, looking at our example, standard 1, patient-centered access, element A is looking just at appointment. Factors, this is what you're actually going to do. So factor 1, provide routine and urgent same-day appointments. Factor 2, the routine and urgent appointments outside of business hours. Okay, so the factor is what you actually do. So what I thought we'd do is take a look at at all 6 standards, and I just pulled a couple elements and factors out of each standard just to give you a taste of what you'll be working at. So standard 1 is what we just looked at: patient-centered appointment access, providing same-day appointments for routine and urgent care. This may be something that you are already doing, and it's also one that is easy to implement to go ahead and get started. Now, there's no set number. NCQA does not set a number as to how many same-day appointments for routine and urgent care that you need, because you know your patients, and this is patient-centered medical home. So this is to be tailored by you around your patients. So you decide what is best. If it's 2 appointments in the morning that you want to block open and 3 in the afternoon, if that's what works best for your patients, then that's what you'll do. Element 1C1. So element C is electronic access. Factors 1 through 6. This is mainly looking at the meaningful use patient portal. So if you're already meeting meaningful use, chances are you've met 6 factors already. So you're well on your way. For example, factor 1 is over 50% of your patients have access. One of these factors is that you can request appointments, prescriptions, or test results. One factor is that you can do secure messaging with your provider. So things that you're most likely already doing. Chances are you might already be doing all 7 of these factors under standard 1. Now, when you do submit to become PCMH recognized, of course there is a yes, we are doing this, no, we are not doing that kind of attestation. But what NCQA looks at then is the supporting evidence that you upload and send to them. So most of the factors that you are submitting, you need to have a policy and procedure in place. And this is one of the biggest things that I hear from offices that I work with, is that so many of their policies and procedures are verbal. They're just what we do. It's what we've done for 30 years. But no, it's not written in black and white anywhere. So this is probably one of the first things that I have offices do, is look and see what policies and procedures they have in place but are not actually written, and have them write them down as a policy and procedure. So for 1A1, the patient access, you would have to submit a policy and procedure. And again, your policy and procedure is going to be based on your patient population. There's no formula that they're going to give you. And then you also have to submit an example. So for 1A1 with a policy and procedure, you'll submit a screenshot perhaps of the appointment schedule for 5 days, so that they can see that you are following or following as best as you can your policy and procedure to have open same-day appointments available. Of course, no PHI is submitted, so it will be a calendar schedule of a lot of black marks, a lot of black or blacked out information. But yes, many of the standards and factors have policies and procedures and an example that you must submit. So that's an example of standard 1. Standard 2 is looking at team-based care. So team-based care, that's a big topic. So that is a standard. 2 of the elements that are in standard 2, element B, for example, is looking at medical home responsibilities. Factor 4 specifically in 2B is looking at education and self-management support. And PCMH is very focused on evidence-based care. So who in the organization is behind that algorithm? Are you following the CDC's immunization guidelines or American Heart Association's protocols? And the education that you're providing, who is behind that education, just to prove that it is evidence-based education. 2D3 is looking more at the team practice. Now, many of you have heard this called a team huddle. So factor 3 is on the team huddle. And what a team huddle does is it discusses today's and preps for tomorrow's appointments. Of course, there will be add-in appointments and such, but the majority of the appointments, you can have a brief run-through beforehand so that the nursing staff can have things ready and in place, and the patient is prepared when the provider goes in. So what needs to be done behind the scenes before that provider sees the patient? So are their labs back? Is there any special report that you've been waiting for? Here's an example, not a very good one, but an example of a team huddle. And what you submit for this example, you would submit a policy and procedure that 5 minutes before the first patient, there will be a team huddle between the staff and the provider, and then you would submit an example. The examples can be chicken scratches with arrows and stars and things like that. It can be something more formal. It's whatever works for your office. So 5 minutes before patients are seen for the morning, we can see that we have a new diabetic patient. So you can start the plans and making sure that the health coach is aware that a new diabetic patient is coming and that there will be an appointment scheduled. Make sure they have the last labs and their shoes off. So that is all taken care of before the provider goes in. Bruce Doe is just discharged from the hospital. So make sure we have the hospital discharge report. Update any new medications, do some medication reconciliation before the provider gets in there. And this will avoid any delays in the provider being with the patient, working with the patient, because they already have that discharge report in hand. The medications have been updated. Jane Bloom, very healthy 3-year-old, all the vaccinations can be drawn and ready to give. Yearly checkup for Billy Roberts. So make sure we have the last labs. When was the last colonoscopy? Is he still seeing that specialist? And let's make sure we have that last report. All of this can be done in 5 minutes or less. And actually, the offices that I work with, they tell me that this factor has improved their daily workflow so extremely much by taking 5 minutes of your time and looking ahead and making sure that everybody's on the same page and nothing is missed. This has made a huge impact in a lot of the providers' days that I work with. Okay, let's move on to standard 3. This is looking at patient health management, population health management. Again, a huge topic. 3B, this is looking at a lot of meaningful use. So use of the electronic system for clinical data. If you are getting meaningful use reports, most likely that is what you will submit for this. So things like medication list, problem list, can you capture that and submit that? D and E are also meaningful use objectives, but looking at patient reminders, patient lists, clinical decision support. Element D is adding a step at proactively identifying the population of patients. So if you want to focus on diabetic patients, for example, or depression diagnosed patients, proactively identify them and remind them of care that is needed, again, being evidence-based. Again, you would submit a policy and procedure, as well as reports showing all of the patients that are due or overdue. Of course, it would be no PHI. And then an example of how you communicate with that patient. So is it a letter? You could upload a letter. Is it a telephone script? You could upload the telephone script or take a screenshot of the patient portal message saying that our records show that you're due or overdue for this, and then evidence-based. According to the CDC, you must receive this vaccination, okay? So again, you're having a policy and procedure stating that this is what you're doing, this is how often you plan to do it, and then an example that it's being done. Now, this doesn't mean to imply that the policy and procedure is all going to fit in place with no issues, but that's why they encourage you then to revise your policy and procedure to make it fit for your patients in your population. Standard 4, care management and support. Big topic again. A few of the elements under Standard 4 are looking at identifying patients for care management, care planning, and self-care support, and then support that self-care and use shared decision making. So 4A, 1 through 6, this is going to take a little bit more planning at looking at your population. Who or what diagnosis would benefit from some additional assistance? What behavioral conditions do you see, or what complex or poorly controlled patient diagnoses do you see? Certain social deterrents. So you would identify patients for some care management planning. For B, is you would the patient and the care team would develop a care plan with goals, address barriers to goals. Is it the patient's work schedule or financial resources? Is it a health literacy issue? For E, is looking at providing education and community resources outside of your site. So elder house, Meals on Wheels, prescription assistance. Is there a Y that provides some healthy cooking classes and exercise classes? Using those materials to help the patient manage their own health. Here's an example, a couple of examples of individual care plans. So the 4B, 1 through 5. It would be working with the patient, having the patient recognize the problem and their behavior, barriers, having them determine some possible solutions to barriers. So this isn't somebody sitting down with the patient and telling them what to do. This is, again, a team approach, shared decision making. The patient having them decide some possible solutions to barriers. I know this sounds like a lot and extremely time consuming. Who's going to have time to do this? Remember that becoming a patient-centered medical home, that it's a transition. So different people in your office will have some different roles. There will be different workflows that you'll be transitioning through. It's not always easy, and it certainly doesn't happen overnight. But offices, they do see the benefit. Information is out there showing the value of this transition. Here's another action plan. Again, it's the patient, what's your confidence level that this will happen? This is more of a contract, and these are ones that I just Googled. You can get a lot of examples out there, or definitely create your own. Okay, looking at Standard 6, this is about care coordination and care transitions. So it's about coordinating care between providers and following up on care with the patients and providers outside of your site. So A is looking specifically at flagging abnormal test results and notifying the patient or family or caregiver. Where C is focusing on shared information with other facilities, such as specialists or hospitals or rehab. So again, using meaningful use objective for summary of care, that is looking at, or that would fit under element C, sharing information with facilities. So if you're using direct messaging or whatever your EHR solution is to care coordination and electronic summary of care, that would fall under 5C. somewhere in factors 1 through 7. This is just a fun quote from the Institute of Medicine, that how important it is to talk together between patient, primary care physician, and specialist. Work from the same blueprint. Here's an example of test tracking. Again, you would have a policy and procedure that you would need to submit, but then also an example of test tracking. Now, this is kind of a messy one, but this works for that office, so that's perfectly fine. Some of your EHRs might produce a very nice, clean report. Again, you use what works for your office, as long as it contains some certain things. So, who's the patient? When was it ordered? What was ordered? When were the results received? When were the results provided to the provider and to the patient? You can see that you're definitely missing some test results. So another factor is then, okay, who has the job to go back to the lab and find out where these missing results are, so that things aren't missing. Finally, standard 6. This is looking at performance measure and quality improvement. So how are you doing? How are you going to measure that? How are you going to track that? So 6A, factors 1 through 4, they look at CQMs, basically. But element D goes a little bit beyond by looking at patient experience and staff experience. And then you develop ongoing training or readjusting the current process to better fit the office. So you'll note in all of this that medical homes, they're not cut and dry models. Each medical home develops their own goals and standards to measure and live up to. You can use the PDSA method, the Plan, Do, Study, Act, because everything that you're doing is being constantly reviewed and measured and adjusted, and that is okay. Here's an example of something that NCQA provides that you may use. You don't have to use, but you may use on QI tracking of clinical quality measures. So you have the measure, the opportunity identified, what the goal is, what the action is that you're taking, remeasurement of the goal, any improvement or not. So when considering becoming a patient-centered medical home, it's status quo versus transformation. So are you ready to transform your office? And again, this is not happening overnight. You're not going to walk into a totally different environment tomorrow. This is a process. So you might want to start by looking at your mission statement. Is your mission statement, is it all based on the patient? Is it patient-centered? Maybe take a step back and look at that mission statement. Maybe it needs a little tweak to make it patient-centered. This is definitely a team transformation. So you need to get everybody on board and excited about this process. There will be bumps in the road, but that's okay. Assign roles, do the Plan, Do, Study, Act, or something similar so that you can see your progress. Why become patient-centered medical home recognized? At this point in Indiana, there's really no financial incentive. As I said, it is a lot of work. You can see that there are many factors. Again, you don't have to meet all of the factors. It depends on how many points you are wanting to obtain. Most practices take 6 to 12 months to collect the data and to implement those policies and procedures. The policies and procedures need to be in place at least 90 days before you can submit. So that's one of the first things I recommend to my offices as to what missing policies and procedures are there, and then let's work on those to get those in place, because they do need to be in place for 90 days. Your system works as it is. Otherwise, you would not be in practice. It does cost to submit the data. At this point, PCMH recognition lasts for 3 years and then you reapply. A big change is going to come next year. So I still encourage you to get started with patient-centered medical home, but then there will be some changes. I believe the final rule will come out in March of 2017, but that will be interesting to review and see what changes there are. And probably the scariest thing for an office is that it does require a culture change, okay? But again, it doesn't have to be overnight. It is a process. So when you think of it this way, it's a lot of work to become patient-centered medical home recognized. However, when you look at the results that are occurring out there, at the success stories that are occurring out there, they're huge. There are some patient-centered medical homes that have been developed by certain state insurance carriers or payers, and they have collected some amazing statistics, evidence that patient-centered medical homes make a difference. So Minnesota, for example, this payer, their information that they have received, there's a huge reduction in appointment wait time, 26 days to 1 day, because of 1A1, the same-day patient-centered or patient appointment access. My thinking is because of that one, the first two have occurred, lower ER visits and fewer hospital admissions, okay? So you're getting some very good results there. New Jersey has some great results. Screenings have gone up. Self-management of blood sugar. Pennsylvania has some great information on blood pressure and cholesterol control, self-management goals. Texas, some huge increases in screening rates. And again, this is going to keep people out of the hospital because they're being screened early. So again, when you think, why become patient-centered medical home recognized? Yes, it is work, but when you look at the benefits to the patients and to the practices, you know, once practices get into that transformation mode and see the results, it's very exciting, and they're very happy to become a PCMH. So improved access to care, these pilot programs are showing, lower costs. So it really is triple aim focused, which is wonderful. And it transitions the physician care supported by clinical staff to patient-centered care directed by the physician. It also has a tendency to transition appointments from episodic care to preventive care because you're bringing patients in for more screenings and follow-up if they're overdue or if they're not compliant. You're helping with those self-management goals. So I would highly recommend, if you're interested in becoming a patient-centered medical home or reading more about it, to go to the NCQA website and download this latest standards and guidelines. It is free. I believe you do have to just set up a free account so that they can email you the link to get the standards and guidelines. And then set aside a couple hours and go through all of the factors. Check what is already being done. See how many points you've already accumulated by what you've already done. And again, a lot of things you've already done, but maybe they're just not written down. Those are easy ones to meet. There are ones called, are elements called must-pass elements. We did not talk about them, but they are exactly that. Each standard has one must-pass element. So it's just that you must pass that element with 50% of those factors in order to get points. So yeah, there's a lot of little details which are easy to understand once you start to get into it. And finally, create your plan. Remembering policies and procedures need to be in place 3 months. Get a plan in place. Decide what level you want to be of a PCMH, how many points you want to go for, how many points you think you probably already have, and then create your plan to get the rest. So that is what I had. Hopefully that was a helpful overview and a little taste of PCMH, something from each standard. You're more than welcome to reach out to me with any questions that you might have. I'd be more than happy to answer anything for you. So, Allie, I'll turn it back over to you.
Well, thank you so much, Jennifer. I have not had any questions come in over the chat, so we can hold on just a second to see if any more come in. But in the meantime, this will be posted probably in the next week or so on our YouTube channel, the IRHA's YouTube channel. So if anybody has any questions who's viewing that, you can see Jennifer's contact information there. I'm sure you don't mind people reaching out to you at any time. It doesn't have to be directly after this presentation, right, Jennifer?
Oh, of course. Yeah, reach out to me by phone or my email anytime. I'd be more than happy to answer questions for you.
Excellent. Well, as I said, we'll leave the line open for just a moment longer to see if any questions come in. But in the meantime, we really appreciate your time and for putting this presentation together for us. Very good information for everybody out there. And we just really appreciate all the work that you put into it.
It was my pleasure.